typically our average length of stay in our LTAC is a month. You don't typically stay in a hospital a month for most illnesses, okay? They're going to send you to someone like us. In Lufkin, we have an LTAC. We're one of the lucky areas. We have the only LTAC in our service area in about 12, 13 counties. Now, there are some in Houston and Dallas and Shreveport and Beaumont and some other places, but we're the only one in our area here. And Memorial Hospital System has this LTAC. The next one we'll talk about a little bit is called an inpatient rehab facility. An inpatient rehab facility is when you're ready to discharge from the hospital, you're able to get up or stand a little bit, and you need intensive physical therapy, occupational therapy. But to qualify to go to an inpatient rehab facility, you have to be able to do 3 hours a day of what they call intensive rehab, okay? So a lot of times patients, when they get ready to go to this, they're just not able to do 3 hours a day. And that's a minimum requirement. Sometimes it's more, okay? So if you can do that, like at our hospital in Lufkin, we have it on the first floor of the hospital. It's easy to get in and out of. Patients will go there for a week to 2 weeks, and that'll get them stronger. The therapists are going to work with them every day. They're going to get you up, they're going to walk you, they're going to push you, they're going to get you out of your wheelchair or your walker and try to regain your strength. So the goal is you can go from there back to your home or community setting where you were at. And you need that strength. If you can't do that, then we have an outpatient rehab therapy. And that's where you would go home and you still need more therapy. Okay? But you're able to go out and get that therapy. And there's rules, and Patricia will talk about that in a minute. Or Linda. When you get to that home therapy, you can go to the hospital or to those outpatient therapy centers, and you see a lot of them in the area, Livingston, Lufkin, we all have them. And you'll go to them, and a speech therapist, occupational therapist, or a physical therapist will work with you, kind of like an inpatient unit. And they'll teach you how to do things, how to do exercises, how to get up properly, sit down properly, how to do different mechanics of your body so that you're being safe and you're getting your balance back and you don't want to fall and have another injury. Okay? And then the next one we'll talk about a little bit is a skilled nursing facility. And I want to differentiate a skilled nursing facility versus a nursing home. Most of you hopefully know they're a little bit different, but they're often the same building. Do you realize that how many people here has ever been to a skilled nursing facility versus a nursing home? Have you ever been there for rehab or something? Okay.
Oh, I had my mother there.
Okay. And so what happens is a lot of times you think of a place like the Bradford or Timberwood as a nursing home. But it's also another entity called a skilled nursing facility. And as a skilled nursing facility, they have to offer physical therapy, occupational therapy, and speech therapy. And sometimes a few other therapies. And you go there temporarily. So you may have been in an accident, you may have had surgery, you may have had some kind of illness or injury, and instead of being in the hospital, you go to that place and you live there basically for a week or 2 weeks or a month. And they're doing therapy basically every day. You're just not strong enough to do an inpatient therapy where you do the 3 hours a day. So you can do it at a slower progress and do the skilled nursing facility, okay? Now, the same building is also a nursing home. So you can go to the same places, Bradford or Timberwood or Pine Ridge, and you can be in a nursing home where you live there, that's your residence. And those are long-term.
I'm Patricia Jones, and I'm Director of Community-Based Care for Memorial System. Some of you have seen me in a lot of settings through the years in the setting of community-based care. The one constant that I've had since 1990 is Homecare. And the hospital actually owns its own home care agencies. Not many hospitals do anymore. For a lot of reasons. We're seeing more and more hospitals get back into the home care business because of healthcare reform. It will favor systems that can be streamlined and seamless. The buzzword you're going to hear is care transitions, transitions of care. And the more we move a patient through the same system, typically the smoother those transitions are. We're all on one computer system. We have a common medical record. Those kinds of things. The hospital does not currently have a skilled nursing facility. That's about the only thing we don't. Woodland Heights and Lufkin does. We have our ALT, which Sherry's already told you about. We have rehab, and we have home care. We have inpatient and outpatient rehab, and we move a lot of patients around between those settings, and it's very effective. A skilled nursing facility is covered under Medicare Part A. And so there's not the financial requirements like a regular nursing home. Typically, you have 30 days of skilled nursing care, and it has to immediately follow an acute care hospitalization of at least 3 days. If you're unable to tolerate the number of hours of therapy a day that would be done in inpatient rehab, sometimes they send you to SNF and you come back to inpatient rehab. Or you go to SNF and you go home and you have home care, which can do occupational therapy, physical therapy, speech therapy, all those sort of things at home. The nursing home, we get a lot of questions about the nursing home, particularly financial questions, because nursing home care is not covered under Medicare. And that means that it's going to be out of pocket. If you have long-term care insurance, most of those policies pay about $100 to $150 a day, and that's not going to fully cover nursing home costs. So nursing homes will be subject to what's called spend down. And sometimes people say it so fast it sounds like they mean spend, and you're going to spend somewhere, but no, they mean spend money. And you have to spend down your personal resources to the level that you would qualify for nursing home Medicaid. It also means that if you do that, once you qualify for nursing home Medicaid and you use it, that if you die before your spouse retains your estate. But if your spouse is already deceased and you use nursing home Medicaid, when you die, then the state of Texas owns your estate for the amount of money that they paid for the nursing home care.
Say that again.
Okay. Yes. About 4 years ago. What it means, there's a rule called impoverished spouse. So your spouse cannot be left impoverished. So if me and Jerry are married, and I go to the nursing home, and I die, and Jerry's still alive, he keeps our house, everything stays the same. But if Jerry dies, and I go to the nursing home, when I die, the state of Texas can sell my home and my estate to reimburse itself for the care it paid for me.
Okay, if there's anything left over, where does it go to your estate?
It goes to your estate at that point.
Are all states like that?
I can't speak to that. I'm an expert in Texas.
Pretty much going that way.
Okay, now the spend down, what is the base?
It depends on if the other spouse is still alive.
Okay,
It depends
so
on a lot of things.
suppose they're not.
It's called a means test, MEANS, a means test. And in general, you can have a car that's not worth more than $5,000. You can have savings of not more than, I think, $2,000. But these numbers move based on the consumer price index and a lot of other things, and I wouldn't want to stand here and give you an exact number, but it's not very much money. By the time you have spent down to qualify for nursing home Medicaid, you have spent everything. There was a practice some years back where people would go ahead and just deed their property to their children, set up these accounts and all that, and of course the state got wise to that pretty quick. So now the look back provision is up to 7 years. So if you deeded everything to your kids, put it in somebody else's name, 7 years have to pass before the state is not going to look back at that sale, and if it was sold at less than full market value, they're going to comp the difference.
Oh my goodness.
Okay. And that's about nursing. I don't do nursing homes, okay? I just know this stuff because I do home care. Home care is my thing.
Well, that's good to know.
And it comes up a lot when our
Just gotta
patients
plan way
are
ahead of
trying to
time.
make a decision, you know, as to
Who
whether to
would've
go to the
known?
nursing home or not, what that means. Next is senior homes. These are always private pay. They are usually in a house, senior home, and they're always private pay. They're usually in a house that usually has 2 or 3 bedrooms, and each person has their own room, and then there's a common cook or medication assistants or those kinds of things. And then we get to my part I love, which is home health. And I've been doing home health since 1977. And I've managed clinics for the hospital. I manage a women's health program for the hospital. I managed our dialysis units for 3 years. I've done all kinds of things for the hospital through the years. I even ran the billing service one time for 3 years. But while I was doing all that, I was always still running home health. That's my thing. A lot of reasons why. And you see folks who save their money so that they can have some comfort. But where they're always thinking about buying those comforts is in their own homes. They're not ever planning to spend that money to pay a nursing home. And one of my favorite stories, and y'all can drag me off with a hook, but one of my favorite stories is we had this little lady, and this has been about 15 years ago. So everybody involved in this story is long deceased, okay? But there's this little man, and he lived in a small town, and his wife was just mean. And he was the sweetest fella, and he was real tall, and she had to have a leg amputated, and she just terrorized him. And what he really left to do was to go play dominoes. And every time that little fella would try to go down to the local place where they all went to play dominoes, she would have a hypoglycemic attack. And we all felt so sorry for him. And so one day she had a hypoglycemic attack. She would do just like that. She was so dramatic. She had one of these attacks, and she refused to go to the hospital. And it was Friday afternoon, late, and the doctor found it is deer season, to make matters worse. And her blood sugar just keeps dropping and dropping, and I have a nurse in the house, and she's doing these blood sugars on her, and they're just getting lower and lower and lower. And I don't know if any of you ladies are diabetics, but you know, you start getting below about 60, and it starts getting really serious. And she refused to go to the hospital, refused to go. Finally, I have to call the county judge's kid and get her to get on a four-wheeler and go get her daddy off the deer stand and come back for him to issue a court order for the ambulance guys to load this lady. And it's raining, it's pouring rain, it's fall. So they bring her in, and by the time they get her to the emergency room, her blood sugar is 40. And they barely saved her. So Monday morning, you know, she's in the hospital all weekend, and I go over to check on her. And silly me, I think she might say something like, "Thank you for missing your Friday night dinner plans to stay here and save my life," you know. And so I walked in and I said, "Miss So-and-so, I'm Patricia Jones from Homecare." And she said, You're that heifer that had me drug out of my bed in the cold and the rain and slung in the bed up here." And started out after me. And I was so stunned that if she had not been an amputee, she'd have got me, because she is swinger cane, and her poor little husband's just mortified. We get her back in bed, and I take him and I go out in the hall, and he is just shaking like a leaf. And he's tall. And I said, "Mr. So-and-so, you're just going to have to hire you some help. And hire somebody to come in and sit with your wife for a couple of hours twice a week and let her know that that person's coming. She'll get used to them. Get another lady she'll like. And you go play dominoes with your friends and just get out a little bit. It would do you so much good." And he said, "Well, I can't get any help." But, well, by help he meant providers. And many people, when they think of home health, that's what they think of as providers. And those are the same qualifications as nursing home Medicaid. And those are people who come in and do household chores. And I said, "No, but you have that $70,000 in savings, and you can use that and hire you some help." And he said, "Oh, I can't use that. That is the money I'm saving for my old age." He was 87. So I tiptoed the best I could, and I caught that little fella by his lapels, and I pulled his face down to mine, and I said, "Mr. So-and-so, this is it. This is what you have been saving for." So we helped him a little bit, gave him some names, he made some calls, he hired somebody. She went home, he hired the help, came in twice a week for 2 hours. he took up dominoes. She lived 3 more years. And he lived 5 more. But sometimes it takes somebody saying, this is it. So that's what providers do, whether you pay them privately or whether you get them from through the state. What Homecare does is provided for you through Medicare Part A and Part B. And it was implemented originally, years ago. I bet you can remember with your parents checking them in the hospital just for tests or just to rest a few days, check them out, those kind of things, no more. And so Medicare implemented what was called a prospective payment system. And what it did was just say that for this diagnosis, a person ought to only be in the hospital this many days, and then they got to go.
That's what they do to us.
Y'all are familiar with that? Yeah. And so when they did that, as a safety net for patients who were probably going to be dismissed from the hospital quicker and sicker, they put the home care benefit, and that was in the early 70s. And the home care benefit at that time was a blank check. The more times the home care agency came to see you, the more they got paid. There was no co-pays, no deductibles, because they were saving more money than they were spending by getting people out of the hospital quicker and sicker. But home care was the safety net, and that worked very well. But what happened was home care evolved into a long-term care program for people who had too much to qualify for providers. And because if you had a skill need, something that could only be done by a nurse or physical therapist, then you could also have a personal care aide 5 days a week, all paid for by Medicare. And that became Medicare's long-term care program, and Medicare's determined not to be in the long-term care business. So in the late, about 98, Medicare changed the way they reimbursed home care agencies till the same way they reimbursed hospitals. And that was, you get a flat amount of money to have this person on your service for up to 60 days. No matter if you go see them 5 times or if you go see them 50 times, you get the same amount of money. And in that 1 year, half the home care agencies in Texas closed in 1 year, in 1999. So what we're left with is a benefit that very much mirrors the hospital benefit. And the purpose of the Medicare home health benefit, you have to be homebound. And in my interpretation, and in the interpretation of the Medicare auditors that I have dealt with through the years, that means you do not drive yourself. Somebody else can drive you, but you do not drive yourself. There are some home health agency administrators, and I have to have an administrator's license from the state, separate, because we are a department of the hospital, but we're a separately licensed home care agency. Some home care administrators take a little bit broader view of that. I served 4 terms on the board, the executive board of our state trade association, including on the board when we sued Medicare to try to stop the PPS system that caused half the agencies to close. And I've had the unfortunate opportunity to deal with a lot of Medicare auditors face to face. And that is the most common reason that home health claims get denied, is it's found out that the patient was driving and they disqualify them under the homebound status. Because that's something a non-clinical person can understand, and most Medicare auditors are not nurses. What I see as the future of home care is that it will continue to be a no copay, no deductible part of Medicare, but it will be limited to probably 60 to 180 days post-hospitalization. Once there's no longer a skilled need. If you have a wound and your wound is healed at day 45, then we're going to discharge it. You know, if you're a diabetic and we're doing diabetic teaching, and I always say you have never taught a diabetic diet until you have taught it in somebody's kitchen. Because it's a whole new ball game out there. And you open the cabinets and you know what they think they have is not what they have. Just something simple like tuna packed in water versus tuna packed in oil. I mean, it could be something that simple that's throwing their blood sugar off. But if you don't open their cabinets, you're never going to know that. So if it's diabetic teaching and we've gone through the steps methodically and you've learned your diet and you've learned the signs and symptoms of high and low blood sugar and what to do for them, and you've learned how to take care of your feet, and you've learned how to work your glucometer, and you're good, and it's day 50, well, then we're going to discharge you. But if you're not good, and it's day 60, we're going to sign you up for another round until we're sure you've got it. Yes, ma'am.
Do you have one home health under the hospital, or are all of them under you?
There are 3 sites. They all report ultimately to me, but there's one in Livingston, and Linda Reed is the supervisor of that office. And you have a physical therapist full-time that's not contract. He's our employee, that's devoted to nothing but the Livingston area. Very nice young man named Michael. An LVN, another RN, and a part-time nurse aide. And then Lufkin has a staff that's for Lufkin. And then St. Augustine has a supervisor over there and staff for St. Augustine. And we do sometimes when there's vacations, well, we float back and forth between offices and help each other out, but we're permanently assigned.
So what's the name of?
Memorial Home. When you price assisted living, assisted is a relative term, because assisted living is the room and the meals probably. But if you want them to set up a medication minder, that's an extra charge. If you want them to directly assist you with personal care, that's usually a little extra charge. So, go in armed with a list of questions. The other thing just to speak to real briefly is advanced directives. If you do not have a living will and a power of attorney for health care, do your family a favor and fix yourself one. They're very inexpensive to do, free. The hospital has them out front. When you register, you fill in the blanks, you get somebody who knows you to sign, they saw you sign it, and you put it in a safe place and make sure that everybody knows that it exists. You can put it on file here at the hospital. I can't tell you how many difficult situations, I mean, I've told y'all how long I've been doing this. I can stay up here the rest of the day telling you all about difficult situations that could have been prevented where children who had been close their whole lives wound up divided at the end, which was the last thing their parents wanted, not over money, which is what we all fear, but over end-of-life decisions for their parents.